Our next two speakers is Charlonda and Frederick. They're going to talk about bias, its impact on provider and patient relations. Charlonda is a director of Medicare program with Innovista Health Solution and Genesis High Performance Network. And she has many years focused on healthcare for vulnerable population. Frederick is a U.S. Army veteran, honorable discharged. He likes to be called as work in the logistic transportation field for over 30 years. Charlonda and Frederick reside in Dallas, Texas, and are proud parents of 5 sons, 1 daughter, and 3 grandchild. Welcome, Charlonda and Frederick.
Thank you so much. I'm going to put Frederick in the frame here for a little bit. Thank you so much for that introduction.
Thank you for coming.
Yes, we're glad to be here. I'll just kind of move it a little bit towards my way, just because before we have Frederick speak, I'll have some slides to share with everyone. But good morning. Good morning. Morning from Dallas, Texas. And we've been up for a few hours and y'all are probably still drinking coffee. So let's go ahead and get started. We're going to look into, of course, this disclosure information as far as no conflict of interest, so our financial relationships there. And then just the objectives, what do we actually hope to achieve today? Recognizing and exposing and discussing about implicit bias and how its foundational causes, or it can be the cause of healthcare disparities and structural disadvantages. And then also applying applicable processes to decreasing disparities and implement sustainable change by recognizing implicit bias and then what to do about it. And so before we begin, I do have a modest request. And my modest request right here is that I ask for all listeners and participants to listen with an intent of your own reflection, also some level of vulnerability, and also a level of imperfection, which I consider to be perfect because none of us are perfect. And so as being human beings, to be imperfect, there's a beauty in that. And to be vulnerable, and to also welcome the opportunity of learning something new about oneself and also about others, because that's what this is about. That's why I love the National Kidney Foundation so much. It's because not only will they offer sessions like this, but that we all do a work that is very near and dear to our hearts. And so being able to learn something new and about for those that we serve is important. And also, to render a personal pledge of just creating where growth and change can be created for yourself. I promise you we'll do the same thing for ourselves as well. And then also to give the gifts of hope, encouragement, and a call to action, because nothing changes if action is not behind it. Righty. So let's actually start here. Most of us have probably heard or seen this type of information, right? So when we break this down into racial disparities in kidney disease, right? And when we think about whether it's CKD or ESRD, as you can see here on the slide, and I won't read all of it, but in a nutshell, what we see is a great disparity where African Americans, in this case, are Blacks, which are only 13% of the population, are 3 times more likely than white counterparts to develop kidney failure. And then when we also delve a little bit deeper into types of modalities, for example, like home dialysis and center, et cetera, peritoneal, we see that there is still a disproportionate number of Blacks, where 71% most likely will be in center. And then for home modalities, where most likely patients of color are not actually utilizing that type of modality. And then also in kidney transplant, it becomes even a little bit more grimmer. National data for kidney transplants has shown that even in predominantly African-American cities or towns, Blacks, Hispanics, Asians, there's still a much larger number, a much smaller number to receive a kidney transplant than white counterparts. And so, and when we think about this type of information, when we think about these statistics, it's more so to kind of just bring into focus kind of maybe what the root cause of this can be, because this is the outcome of a root cause. And so we're going to talk more about that. So let me go to the next slide here. So this slide here, I don't usually like to directly read my slides, but I don't want to miss anything because this is going to kind of just set the foundational reason of why we're going to get into what we're going to discuss today. And so, when we look at the root causes of racial disparities in healthcare, and it's a lot to unpack, but just bear with me as I read through this. But implicit bias and structural racism play a central role in the development of healthcare disparities. So one of the critically important areas in medicine is the misdiagnosis of disease in people with darker skin types due to implicit bias and the lack of awareness among, and in this case, healthcare professionals. But what is structural racism? Well, it's defined as a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity, used to preserve the gaps between white Americans and Americans of color. I'm not here today to say, how can we get rid of, within less than an hour's time of structural racism? I know that it is a lot to be able to digest, but there is a place to start. There is a place to start because as we can see here that the perpetuation of what may start as implicit bias has very grave consequences and continuedness towards racial disparities, or maybe even poor access to care in healthcare. So where are we going to start at then? Well, we're going to start at implicit bias, but let's also define it so that we're on the same page with that. So implicit bias is the unconscious, right? So it's what we do unconsciously, and it's usually negative, and where assumptions are made, right? And usually those assumptions are made about others that we may perceive to be in some way different from ourselves. And that some way different can be, of course, whether it's racial, gender, sexual orientation, et cetera, et cetera. And so implicit bias in our talk today, when I'm actually talking about that, it will be in the negative connotation of implicit bias or IB. But, bias itself is neither good nor bad because we all actually have them. And the reason being is because it's the brain's way to have shortcuts, right? To have shortcuts. And the brain performing one of its primary evolutionary functions of absorbing and kind of organizing information, like I said, shortcutting. So while this form of information is processing, it's highly efficient and it intends, so that we can function on a day-to-day level, but it creates a lot of significant drawbacks, right? So for example, if you're doing assessments all day and whatever, assessments, social work, doctor assessments, physician assessments, nursing assessments, right? Automatically, especially if we worked for a long day or whatever, it's kind of like we group information, right? And in those assessments that sometimes can be shortcuts. And so we may make some types of determinations on those shortcuts that may not actually be stemmed in reality. And so information is taken in, it's digested, and it produces and reinforces, in the case of implicit bias though, it reinforces negative stereotypes about others based on maybe specific attributes, as I stated earlier, like race, gender, sexual orientation, etc. But this is where implicit bias just goes wrong because, again, there's an application of inaccurate information. And I'm not saying that anyone sets out to do that, but the negative generalizations, any kind of generalization, it's like buyer beware, buyer beware, because those generalizations to a whole group of people or to it is never just a good thing, just period. And so for the purposes, of this presentation, as I talked about, implicit bias will be implied as harmful, and also being able that it affects the relationships that not only do we have with our patients, from patient to provider, but also maybe how patients may perceive healthcare professionals, right? And so the additional reality in this, when we talk about implicit bias, is that as healthcare professionals, we are the gatekeepers. I mean, we just really are, to a patient's direct an indirect exposure to treatment modalities, for example, and access to services. Like, for example, what types of dialysis are there, right? We have to share that information with patients or with family members. And we do kind of become the gatekeeper to that, because patients don't know what they don't know, especially if they're new to this. And sometimes many of them can be on dialysis for years. And again, not still maybe have additional information because did we withhold that information, or did we maybe feel like, we talked to them about kidney transplant 5 years ago and they said no then, so they probably don't want kidney transplant, pursue it, today. I remember when I was with the ESRD network of Texas, I remember I would hear some of the professionals that would call me and I say, so when's the last time, you talked about kidney transplant? Oh, that was like 3 years ago, 4 years ago. And I just thought to myself, but don't we all change our minds sometimes? We might have to revisit that. And I'm not saying that that was intentional to maybe not continue to educate the patient or the family, but again, it was kind of like that shortcut, right? I've gone to them before, they weren't interested. Okay, then probably we don't need to have the conversation. But what this means is when we become gatekeepers of information, right? Because, for example, if it's that patient that we love so much and they're bringing ho-hos and ding-dongs like to the clinic because they love us and we love them, right? I'll be the first to say, it's like, oh, Miss So-and-so, there are no favorites, of course. But do we give more information to a patient or a family that we perceive to be a patient that, family that will listen, that will follow through? And then if we have another patient, maybe that patient is not as friendly with staff, maybe, or with us, or that the encounters with them has not gone as well as we want it to. Have we maybe held back information because of, and then fill in the blank, because of those encounters? But what implicit bias does is it spills over into the decisions that we make as healthcare professionals, as far as being able to advance a patient's motives and even a patient's treatment plan. Because again, it could become that kind of situation to where sometimes we may be making those decisions, maybe rooted in implicit bias. But when we think of implicit bias, because it really does feel like an abstract thing, but it really is not, because it looks like different things in different ways. There's the seen, of course, and the unseen. There's the overt and there's the covert, right? And as we talked about earlier in the earlier slides about structural racism as it exists does not exist just by happenstance. It exists because of a root cause of implicit bias that became an action that has become a seeable, known action. It comes out, it has an outcome. So when we look at the root causes of implicit bias, what can that look like unchecked? And as you look at these lists, think about whether it is things that you've observed or things that you have felt or things that you have seen, especially when in this case, we are talking about in the kidney disease world, of where this may look familiar, or for example, it's like things that you feel maybe about a certain even coworker and how you see them kind of interact, or maybe even yourself interacting with patients and families. And maybe there's no way to kind of put a word on it, or you do define it, but maybe sometimes just kind of discounting it. It was like, I've noticed this, or maybe within myself, I noticed that, when certain types of patients come to me, I kind of cringe, right? Like a certain particular patient. I remember, and this is a very minor example, but I remember many, many years ago when I was in high school, and I remember my mom coming home and she said that she had a coworker. And she said that the coworker's husband unfortunately had cheated on her. And so her coworker did not like any woman with a particular name. So for example, and this wasn't the name that it was, she didn't like anybody who had the name Kimberly. And I just chose that randomly. And as I sat there, I thought to myself, how foolish is that? But I don't, whatever brought that pain on and the situations and experiences of my mother's coworker at that time, what I remember thinking was, so she's going to judge every single Kimberly because of what happened personally. And my brain just couldn't compute that. But as I got older, as I became a social worker and, it was able to kind of put terms to words and actions and things like that, what definitely in this case, like as we talk about implicit bias. And so, in that situation, in that type of example, what started off as something maybe unseen, right? In that woman's heart or that person's heart of, I'm hurt, I'm angry, this is a situation that happened in my life, also became overtly in physical actions. She was shunning every single Kimberly by that name. She was, maybe didn't like, and was her actions also show that. So whatever's in the heart becomes revealed. So let's go to this next slide here. Remember I talked about that with implicit bias, it can start hidden, but it always, always, always has actions tied to it. Unless there's this kind of awareness that it's like, wait a minute, I know that this isn't feeling right. And we're going to talk as we get to the end of this conversation today, of, how do we apply strategies when we know that we have certain biases or implicit bias in this case. But on this slide, I just kind of wanted to show you the effects of implicit bias. And every single effect here is a verb, it's an action, because it becomes, it reinforces, it produces, it replicates, it makes, it engages, like confirmation bias, it increases medical distrust, and it even blames and shames with this. And I'm sure it does many other things too as well. But the reality is that sometimes things like this, like implicit bias, can creep up sometimes when we least expect it, and more so because it has not been just that kind of looking at and that awareness of, wait a minute, hold up, I've got to probably be sure and check my motivation behind this. So again, it becomes, it reinforces, produces, etc. So I am so excited to introduce a young man who, by the way, is Frederick Thrower. And I want you to know that before I have my husband, because I want him to be able to introduce his own story and all of that, this is the first time he's actually seen my presentation. And so I did not prep him at all on, hey, you know what, studies show this and research shows this, because I wanted his story to be as organic as possible as he talks about, just his experience as a patient, his experiences, or whatever he wants to share. So let me go. I'm going to turn the screen more to him. I'm going to click on this next one that kind of just has an agenda to guide our conversation. And since y'all have seen me already, I'm going to turn the camera directly only to him, and then you'll hear me in the background asking questions. So, all right. So hopefully that's positioned just well, because I can't see us. So, you know what? Let me do this just to see. Oh, there we go. Okay. Yeah, that's positioned great, babe. Okay. Okay. So Frederick, if you just want to just go ahead and just introduce yourself and just kind of just tell us about your journey along the kidney spectrum and kidney disease.
Well, my journey started with kidney disease, known as a 6-year-old child. My father actually had the same disease that I had as growing up. So I've seen it from the kidney machine being as large as a kitchen table to where it is now, small enough to go in a small room. We used to have it in the basement of our house. So the journey started early, and but then it finally got me about let's say 10 years ago to start and try to prevent it, and then actually becoming a dialysis patient in 2020. But the journey has been, can I say, a little bit rocky and shaky, because wasn't expecting to be on this, and, seeing it, thought I did everything to prevent it, but, again, it came my way, and I'm the only one in the family that has it right now. I have a brother and a sister, they're free and clear. And so, this journey started, it was a little shaky because it felt like, I got sick all of a sudden. I was good for almost 14 years of battling it without having to be on dialysis. And then about, talk about February of 2020, got kind of sick, and it went from being okay to completely gone. So that journey kind of threw me off as a shake. And, I like to be in that active patient of my care. If I feel something, I hear something, that I feel that, hey, that is wrong. Sometimes, there's been a medicine that make me feel well, I immediately start taking it, but I did and let the doctor know. So I've pretty much had a pretty good care with the team that I have as far as my patient care. But then there are also those times where you feel like you're not being heard. You try to tell them what you're feeling, and because sometimes the patient's not heard because they think they already know all the stuff that they know, but still is something that you're not feeling right, even though they're saying this should fix it, but it's not. So, that comes in with a distrust or makes people angry because this is what I'm telling you, what I'm feeling. This is not working.
But what was the difference between that? So you said, because pretty much as you stated, your journey along this has been one where you have great, healthcare team, right? But you said that there have been instances where, where you might not have felt heard or whatever. But why do you think that was? What was, the difference in that and the disconnect and what was maybe your reaction, or what was your perception of why that was? Besides not just being heard, but was it something even deeper than that?
No, maybe I feel like sometimes that there's a perception that the patient doesn't know quite what they're talking about, or what is hurting them, or what's actually what they're feeling and what you think they're feeling, and they continue to tell you this is not right or like that. And sometimes it makes you shut down, and you just sometimes you make the next step, just go with the flow, so you can just do that. But I'm a little bit more vocal maybe than most, and I'm gonna keep talking about it until it gets till it keeps fixed.
Now, so because you and I also have we have friends, right? Because we attend also an African American church, so we have also friends that are in kidney disease. And I know you have actually come home and told me that you felt like their journeys were a little bit different, right? Yeah. And because I remember you saying to me, because let's just be very honest, with me being in this field, yeah. Right, I feel like our journey has been a little bit different because we're able to access, and I was able to say, well, let's call here, let's go there, and of course you picked up the ball and ran with that. But in talking with some of the folks that we know near and dear, how was their story a little bit different, that maybe didn't have that pre-information and education of not only just this disease process, but just trying to access in this system?
Well, many just from my observation, they just didn't have the regulars for as, because most of them, when I say I do it at home, they're like, how do you do it at home? Until you go to the center, and that just a lot of people, I don't think they have that pursuit of maybe to do the treatment at home, and they're not, I don't know if they're exposed to it and they just act like it's a brand new thing. When I say, no, I do it at home, I'm able to do it from home. And I don't think a lot of people are introduced to that, maybe, that they can, hey, take this, let's do this at home, especially if you got a care partner that's going to help you, versus going to the center. When I went to the center a couple of times, I almost, there's nothing against the centers, but most of the time, a couple of times I almost passed out, because I feel like, sometimes they would overdraw, and you would feel like, to keep myself from passing out. So, since the care has come home, it's been much more productive. Haven't had any of those episodes, and some of the patients, some of the people I know weren't able to, or didn't have that, and didn't know they didn't have access to that.
So Frederick, I know that also, with the doctor that you have, because you've seen your nephrologist, and she actually continues to be your nephrologist. You've actually been a patient first for 14 years. And I remember when choosing her, again, your wife having access to, at that time I worked at a kidney transplant. I worked in kidney transplant, and I went to one of the doctors that I really trusted. And I told him what was happening. And he said, Charlonda, okay, let me tell you who is aggressive, who I think, maybe you and your husband should consider. And so in knowing your doctor, who you are very close to, and you've told me that you've shared your fear, even before dialysis, you shared your fears with her, you shared, and what is it about that relationship with her to where you felt compelled that honestly, you could trust her? What was it that, potentially that maybe she,
Well, what she actually did was always been honest with you. There was never really much sugarcoating. I'm good with that. I feel I do better with the just the brute, honest truth. And it's just in the way you present the information to a patient that they feel comfortable with. And she did a lot of that. And I was able to ask her. We had a relationship where I can go back and forth and ask questions. So and she always gave me a direct answer and what she was due, that helped me to make better decisions. And, we just, over the years, we built that trust and a guideline that I know that she, she cares about my livelihood, my health and everything as far as going. I'm just not just a patient, but she knows me because we've been doing it for almost 15 years now. So, and that journey continues to help me to make forward progress on things. And, I can just open up. To be honest, there was a couple of things I was afraid of. Not afraid of, but the stigmatism of what's going on with it as far as like colonoscopy. I got a big fear of that, doc, and I was able to share that with her, and she was able to give me some, to insights where it made it less, as far as less invasive for me to handle and go through. So that was one of the big things that helped me.
And so do you feel like if that relationship was different, would you be able to kind of follow through on your treatment plan as a partnership with her if that was not the relationship that y'all have?
If it wasn't for the relationship, you would question a lot of things, and it'd make me standoffish and not share. When it gets to critical things that I think I need to share about myself or information that's going on with me, some of those things I would hold to myself and probably not get the best treatment that I needed because of the trust factor that you need that I have with her.
Yeah. So any last thing, because I know we got to move on to our next slides, but any just last things that you would just like to say, to our audience, whether from what you've heard today or just some of the things that as a patient that you've experienced, just in summary to that journey?
I just feel like, that if, the patients got to share with you, they want to share everything and they want to get some natural feedback. We don't necessarily want the cliches. We want the real information.
Cliches like what? What do you mean?
Don't worry. Sometimes they like, don't worry about it, but then what is this that I'm seeing? Why am I seeing this? This is the information. This is a part of the treatment or anything that you
not discounted.
Yeah, discounted as like, oh, it's just part of the treatment. I want to know why would I be in this situation at this point? And give me that information straight and deliver it. And I feel like that helps me to really build that trust where I'm not afraid to, or I'm not ashamed to share the information that needs to be shared, that the doctor can give me a better treatment, when I'm able to trust that the information I'm sharing is going to be heard and listened to. So as far as giving me the information or the feedback that I need, because they know me, I believe they can give me the information that I need to feed and calm me down. So that's what I have. Hopefully that helps someone. This has helped me with the information that where I'm headed, the journey I'm headed to get a transplant. So thank you for your time, and hopefully we can ask those questions that you have.
Yes, and definitely I know that we will have some time for some questions. So if you have any questions, directly for Frederick, then please definitely let us know that and put it in the chat. So So just where do we go from here? Well, it definitely is well said that there's always an inner conflict for all of us, right? How does one change or impact one's own biases? How are we able to impact even sometimes the biases of others, right? Those crucial conversations, the moral courage to address disparities in oneself, and even in the healthcare environment. Oh my goodness, it all sounds like a heavy lift, but it really doesn't have to be, because especially when growth and change requires that state of being uncomfortable, right? And that we each have a part to play in that. And what Frederick, I know he shared with me before is that, and he might not have shared that today, was that he did have some concerns around, how would I be perceived as a Black male that has high blood pressure, diabetes, because actually his original diagnosis was FSGS for the failing of his kidneys. And so the responsibility for change, it doesn't come overnight, but with those steps of not only awareness, that awareness of when are your biases most likely to happen, right? In what situations? Is it a certain group of people? Is it a certain gender? What is it? Only you can answer that. And so when you have that awareness, then it's brought to consciousness, right? And it's usually when biases occur, it usually has some form, whether we're sweating or we tense up, or that uncomfortable feeling that comes with, I don't trust them because, and then fill in the blank, right? Is it the way they look, the way they talk, the way they act, whatever? And then the motivation, right? What's my motivation behind, having those concerns about the consequences of unintended biases? Because it does have consequences. Remember, especially in healthcare, right? We have to strive, right? We got to do better because we have so many lives like in the palm of our hands, and we make decisions day in and day out that can actually affect someone's life, actually for the rest of their lives. So with the willingness to exert efforts to eliminate them, and I'm actually going to give you a quick example of what these steps look like. And then there's also implementation, right? Exerting useful techniques, such as undermining those stereotypes, right? Looking for information that squashes and just cuts to the core of that generalization and unjustified implicit bias. We have to be intentional about that. We just definitely do. So again, it's awareness, it's motivation, it's implementation, and guess what? It's wash, rinse, and repeat. Wash, rinse, and repeat. So for example, awareness, let's say you see an African-American or a female, maybe 50 years old, or Hispanic male who doesn't speak a lot of English, where English is a barrier, and maybe you recognize a bias there. And the motivation is, why is this so concerning? Okay, if I do not actually look past what I maybe physically see or am feeling inside, so what is overt and covert, right? That it has to be concerning enough to want to change it. So maybe, for example, the implementation or the reduction strategy to undermine that stereotype and whatever it might be, may be that, no, that is not just that person in their social context or category. That is not just an African-American female who's 50 years old, or a Hispanic male that does not speak English. Where is his interpreter? Did he not bring a translator? How are we going to do this today? But it's more so seeing that female or that Hispanic male is also a father, a mother, a business owner, worked 20 plus years doing It goes beyond just the social context of the patients that we serve. And we have to look at it in that way, because then it humanizes who's actually in front of us. Now, I am not saying that there are not difficult patients. Y'all, I used to work for the ESRD Network of Texas, and I was the director of patient services director. I know grievances. I surely do. So I am not saying, but also I have to realize that somewhere those difficulties started because of the fact that trust was lost. that things went wrong over and over and over again. Because again, each of us, we have biases. Yes, patients bring them to as well, but right now I'm not talking to a group of patients, right? The accountability and the responsibility lies within our own practices. Here I say social work practices because I'm a social worker, y'all, so I think social work brain, but it's not just for social workers in this respect, but we have to support one another and be able to fulfill those fundamental truths of social justice and dignity and things like that. One of the reasons why I survived in kidney, I feel like the kidney community for so long, because I was there for 17 years before I took my current position, is because I love the nurses and the doctors and the team and the social workers that I worked with. They worked hard day in and day out, but we also had to hold each other accountable on many, many different things. And sometimes that even being implicit bias. And so last but not least, there is no better exercise for the heart than reaching down and lifting people up. I don't know about you, but sometimes I'm like, life is a little bit too hard for me to have to work on or fight battles in the sense of that I don't want implicit bias and things like that to actually, to bring me down. I want to be able to, where it is an environment where patients and their families can actually come, and even coworkers can come and not have to be subjected to things like that. So the goal today on implicit bias was not to approach, with trepidation, definitely not, but rather to explore different forms of implicit bias and just how to be able to work on overcoming that. So if we can go ahead and go into questions, that would be great. If we have any, we may or may not have any.
Oh, we have plenty of comments.
Oh my gosh, okay. I hope I left y'all enough time. I'm sorry.
Thank you so much, Charlonda and Frederick. That's just wonderful. There's so many comments and there's quite a bit of questions. If for the sake of time, forgive me, audience, if I'm going to start with a question, then we come to comments if we have time. Bernadette Vincent has a question. Frederick, do you speak publicly to educate others about this other than today at NKF Symposium? I have the same question. Your story is very powerful.
No, this is actually my first time.
All right, we'll arrange more for you.
Okay, thank you.
Now we'll say he is speaking in Oklahoma next Friday. We're doing the same session for the Oklahoma, and he's been a little bit busy. He did join the local ESRD network with their PAC, but he hasn't been able to be as active.
Right. Well,
still work. So
yeah,
Benedict, we have the same idea. Let's plan this. Megan Evans has a great question. She asked you about, can you give some example of an impact for experience you had with a person that made you feel heard and understood? Is there any advice you have for us to build trust with other patients, with our patients?
I think the problem is that I was having a treatment, and we had to call in when we feel like there's something wrong, and I kept explaining to the person. They kept saying this, and I said, that's not what I'm talking about. I had to be more boisterous with it to get that point across, that I've done what you're telling me, but that is not corrected. Yeah. So, they finally heard me after I kept saying, no, that is not it. Yeah. This is what is going on right now. So they finally heard me. And then, when I got to, this was just like a call-in nurse, basically, overnight. But when I got to my people that were on my actual team, I explained to them. So the next time everything was, went a lot better.
Great. Yeah, we definitely need to hear more about your experience. That's the whole thing about today's symposium. We listen to our patient, what's more important for our patient. While Dr. Hussein has a question, he said, I heard listening, understanding, respect, and shared decision. Any tips for how to make this the standard at dialysis units?
Well, I think, to make it a sin is just, I think it's a little bit more personal than I'm just here, patient number 125. A lot of just, I think sometimes it's a small talk that gets people to open up because, you just come straight medical questions, it's just not, okay, so you have my person too. So I think that too, if you're more concerned as a person, gets people to take down their wall protection, and they'll say, okay, now I can talk to you a little bit more, and they'll open up. And
can I add to that? I just wanted to add to that too. Even though I've worked in kidney disease, we do, of course, home, but while Frederick was in the center, and even with some of the home modality, for example, they'll say, oh, Frederick, your phosphorus is at this. And it's the number, it's just the number, right? And I'm even sitting there like, dang, I don't even remember these numbers, what's optimal. And so what happens is there's kind of like this talk over our heads. Right. And because keep in mind, this is my husband. So all that what Charlonda did as a nephrology social worker, it almost doesn't come into play because I'm just trying to look at and make sure what his situation is. And I would say, do not treat me as if you think that I would know it all. But I think that there is kind of this disconnect sometimes, and it's not how you feel. Like the situation he just talked about is with his permacath. And all when he called that night nurse, all he said was, oh, well, we just have to take it out. And Frederick was like, please don't tell me that. I'm trying to work with this. We're at home. It is almost midnight. We're trying to work this treatment. So I hope that answered the question.
Yeah. We need to write a book about this, all your experience and the wrong way, the correct way, so we can communicate better. There's so many comments here. Everybody like me, I was really thank you for this great talk. And I keep getting this. We have 8 minutes left, but let me try to see as much questions we can. With the change in social media happening, or the misinformation created in the media at this time, how can we hope to recognize, hold on a second, the question went away, hold on. How can we hope to recognize these implications as they arise?
Most definitely. It's because remember, implicit bias becomes outward, right? And sometimes I believe that it is kind of checking with your patients. It's also checking with your coworkers, like, how am I doing? How can I better support you? Instead of already making the assumption that this and this and this will give, and fill in the blank will give support. And the reason why I say that is because, especially even as it definitely has a very different connotation with even what I did as a nephrology social worker. And in fact, as Frederick, for the years that he was, CKD, and as he became on home dialysis, my prayer was that I did not hurt anybody unintentionally, because, it was my job, right? Even though I come with the best of intentions, I sat there and I said, oh dear God, I pray that I did not miss something or cause someone to hurt even more, just because maybe I didn't take the time not to respond, but to actually listen, right? But to actually listen and not just respond back because, I've got all these other things to do. And we know that it's a busy environment. However, though, some of the implications can be a long time, like for a patient that might shut down with that. So you're right. Social media has played a part in that. And I think that it just has to be that conversation sometimes of, so how am I doing? I cannot imagine Frederick cannulates himself. I cannot imagine if he went into the center and he's trying to help someone because he knows how to do it. He's trying to maybe guide, because he has had to go into the center, right? And so trying to guide someone and then them feeling like, I know what I'm doing. This is my job. Right. And how that may also cause him to distrust.
Right. Well, I'm glad you're doing home hemo. Yay, way to go.
Yeah.
So this is a great question from Angelo Nero. Are there some tips that you use when separate those bias between innocent misunderstanding and the deliberate trolling of the social media youth?
Yes, I think that it's important to know that none of us are perfect. None of us are perfect, and that misunderstandings, because I've been there too. And actually I just had to ask, because what happens was I found a patient that was kind of standoffish from me, as before that was not the case. And I feel like that so I actually went to her. I was like, because at first I was like, well, I didn't do anything. Why I got to say something to her? And I went to her and I said, I've noticed this. Am I mistaken? I noticed that if I come into a room, you'll look the other way. I noticed that, when we are, like if I had to do my assessment, she would just answer the questions and no elaboration. And then I found out that there was something I was not aware of how I had offended her, or it was a misunderstanding. And I think that what we have to do is, as human beings, we just have to connect with each other in the sense of, again, doing that checkpoint, right? And allowing that, if there is, allowing patients and saying to them, if there is something that we missed today or in our conversation, please let me know. If it's something you feel like I didn't hear, please let me know. Just those simple things. Because I feel like the reason why Frederick is so close to, and I have thanked his nephrologist over and over again, and I would say her name, but I didn't ask her. So I was like, but I love her with everything within me, because he tells her things that even I'm not aware of. And I'm glad for that. But it was also her just approaching him and saying, how can I help you? Have you heard this? Okay, well, what, and it's like teach back. What did you hear, Frederick, that I said? So I think that has to be that it really truly is partnership, and not just you're in this dialysis center, and so therefore we're the only pros. Yes, we are,
Right.
But that's not the only part of the story.
Right. Partnership. I love this term you use. I think that's the key word here. We are really a partnership in this journey together. We are at the time we need to wrap up. There's one question from Sarah, but I think we'll directly send it to you so you can answer to her privately. Great. And there's many comments. So thank you so much. Just such a wonderful talk. Thank you.
Thank you so much. We appreciate it.